hit this. Hi, Dr. Olumi.
Good morning.
Hi, thank you for being part of our conference. Really honored that you're here. We met ever so briefly about 4 or 5 years ago at an American Urologic Association meeting, and it's good to see you again. A brief introduction, Dr. Olumi is professor of surgery at Harvard Medical School and head of the urology department at Beth Israel Deaconess, which is the hospital affiliated with Harvard. You have an extraordinary research record. I noticed one of your papers has over 1,000 citations, and you know, that's really stunning. I mean, I think the most I've ever gotten is 27, and you know, so it's total honor that you're here. Let's talk about transgender women and prostate cancer.
Sure.
So how is it that women have prostates in 2022?
Yeah, so it's an emerging field. It's new, I think, to our whole community, and many cisgender men who sort of go and become a transgender woman at different stages in their lives, where their male internal organs are still intact. This is the group of transgender women who present themselves with prostatic issues as they age, and I think our whole field is learning how to diagnose and manage this sort of newer population of patients to our medical community. In general, I think this community has not had appropriate medical care. That oftentimes they're not receiving the same degree of medical care as cisgender patients, and therefore prostate cancer management, prostate cancer diagnosis has not been at the forefront of their care usually. I have some experience in caring for some transgender women with prostate cancer, and with each one I learn how best to manage the individual to their needs at the time, and it's this diagnosis in this population is presenting a new forefront for our community of learning how best to screen for this type of cancer, and how best to manage it. Screening can be quite challenging because of the changes in hormonal levels, and how we have set normal standards for cisgender men to assess for prostate cancer screening, and I think those levels are less defined or poorly defined at best for transgender women, because it can vary significantly based on age of presentation, the duration of hormonal manipulations in their body, which poses challenges for healthcare providers of how best to move forward.
Yeah, and in simple terms, a transgender woman is a transgender woman when a transgender woman says she's a transgender woman.
Right.
She could be physically fully, equipped as the cisgendered man that she was born as, or she could be fully surgically, adjusted to fit her understanding of who she is. That alone should, as you just described, presents extraordinary challenges around diagnosis. How does the average, what would you say to the average healthcare provider, the general practitioner, who's, seeing a transgender woman as a patient? How do they even approach the idea of prostate cancer?
Yeah, so again, there are no standards set yet, and I'm hoping that as we see and gain more experience in managing transgender women for prostate cancer screening, we can develop better standards. I think it's important for this type of conversation or diagnosis to be had with a healthcare provider who has some experience in this area, obviously, to know the nuances of how to care and manage transgender women. So I think having a specialist who is better educated for caring for transgender women would go a long way for proper management.
Well, let's take just a brief, quip of an example. What would a digital rectal exam be like for a transgender woman?
So, as for someone who has not had any transgender sex affirmation surgery, the exam would be the same as it is for a male patient. For someone who has had transgender reaffirming surgery, I would imagine that the prostate would be accessed through the neovagina that would be created and evaluated. We have one of our specialists. I don't perform the transgender reaffirming surgery myself, but I understand that depending on how the neovagina is created, palpation of the prostate can be easily accessible. And in some cases, if the neovagina is not made lengthy enough, then palpation of the prostate could be quite challenging. So that's just a simple exam could significantly vary if someone has had transgender reaffirming surgery or not. So.
Right, and blood tests are still, you draw from a vein, but the interpretation of what a PSA is, that must still be in the realm of art form as far as how a physician interprets that for a transgender woman who's undergone hormonal, adjustment and such.
And I think that's the modifying phrase that you mentioned, that if they're undergoing hormonal manipulation and for how long, the PSA levels cannot be taken as sort of the normal standards that have been set. Many individuals suggest, many experts suggest that if a PSA is greater than 1.0 nanogram per mil in a transgender patient who has had at least 6 months to a year of hormonal treatment, that anything above a PSA level of 1 deserves additional investigation. Whereas for cisgender men who are not treated with any hormonal medications, that cutoff is typically at a level of 4.0 nanograms.
So given the difficulty in sort of understanding how to do diagnosis, let alone actually come up with any degree of certainty as to whether somebody should be doing perhaps an MRI and understand their PRADs and such, the idea of presentation of disease is interesting. Is it fair to say that it's more that in 2022 going into 2023 that it's more likely that transgender women will present with an advanced stage form of prostate cancer than not?
Yeah, so that's I think it presents as a challenge and an opportunity for the field and for the patients, because patients who have been treated with hormonal manipulation and are diagnosed with prostate cancer, by definition, their prostate cancer is at an advanced stage by being castration-resistant prostate cancer. And typically, in cisgender men, we do not see that because, at least I've never seen it presenting at that stage upon presentation. So it presents itself as a challenging stage of disease for not only diagnosis, but once the diagnosis is made, treatment options and treatment opportunities. But the opportunity is how we use and evaluate the biology of the disease at this stage, where we can come up with better and newer therapies for patients, for transgender women. And also, I think those biological findings could translate into helping everyone who is diagnosed with prostate cancer.
Sure. And, and that's a good point as well, that any investigation of what are typically called outlier kind of patients, present people with just unique, presentations of themselves, either physically or even psychosocially, present opportunities for all of us, to understand the disease in any form is gold for our field. What might a transgender woman at any stage of her transition sort of expect from a visit when she visits you or someone like you, a urologist?
So, we would obviously go through a history and physical exam. We would assess for any urinary symptoms and any family history of prostate cancer. If there's been family history of prostate cancer with advanced prostate cancer or death from prostate cancer, that definitely heightens our awareness. And it should also increase our likelihood to screen those patients at an earlier age. If there's any history of any genetic mutations in the family, like BRCA2 genetic mutations, that should also suggest earlier screening for prostate cancer. Physical examination would be performed as discussed earlier, whether through a transrectal evaluation or through the neovaginal evaluation for palpating the prostate. And I think it's not mainstay, but I think it would even be reasonable for transgender women to undergo a prostate MRI evaluation, even in the absence of any heightened awareness about their PSA level. The science is still very poor or unknown whether prostate MRI would be helpful, but I think because we know very little about how and when prostate cancer could present in transgender women who have been treated with hormonal treatments, I think we need to provide all access and all opportunities to diagnose the finding at the earliest stage possible, and also to learn which strategy lends itself best for screening and effective treatment.
Yeah, and just for the patient who has a neovagina or had any sort of surgical alteration to their body, are biopsies conducted in a different manner?
It can. So biopsies can be performed through the neovagina, but also transperineal biopsies can also be performed. I think more and more centers are becoming comfortable with performing transperineal biopsies where we are not traversing the rectum or the neovagina. That could pose itself some challenges and also potentially damage to reconstructed surgical sites in the neovaginal area. So transperineal biopsy would probably be best reaffirming surgeries.
Right. So it's fair to say that trans women should not be at a heightened degree of anxiety around any more than a cisgendered man around prostate cancer screening, diagnosis, and evaluation. Is that fair to say?
That's fair to say. I think they should just be even more educated and be more proactive in requesting prostate cancer screening. Prostate cancer screening in the population as a whole, has decreased over the past decade, and we've sort of altered or modified how we recommend to our general population whether they should or should not get prostate cancer screening. So many primary healthcare providers don't offer that because of some of the bad publicity that prostate cancer screening has received because of all of the side effects associated with the therapies. But because we have gotten better at sort of minimizing the treatments and tailoring the treatments to individuals who may benefit the most, I think prostate cancer screening has sort of regained some popularity again compared to 10, 12 years ago. And I think transgender women should advocate for themselves to definitely get prostate cancer screening because the biology of the transgender woman, because of the hormonal manipulation, is very different, and cancer presentation could be very, very different in this population.
You know, for cisgendered men, 50 years old is sort of a common number. Age for you know, a consideration of screening. Malecare recommends 40. You know, I mean, I mean, there's no data obviously, but to support anything to suggest younger for transgender women. But does your gut tell you it might be advantageous for transgender women to start screening, at least with a blood test and digital rectal exam, if they're already transitioning at age 30 or younger? Or around that age? Yeah.
I would definitely say at least 40. And I think it also makes a difference of how long, what's the duration of their hormonal treatment that they've had. So I think a reasonable cutoff would be to start at age 40. So.
Right. And do you see like an even higher presentation of prostate cancer for African American women who are transgender?
I don't have enough data points to give you a fair answer. Extrapolating from cisgender men, one would think that that may be the case, but I don't think there's enough data available to make that statement.
Yeah. Let's talk a bit about management and therapies and such. To what extent should transgender women, the women, you know, the ladies listening in our audience now, what are the questions that they should be insisting are answered by their oncologists and urologists and radiation oncologists?
If they're diagnosed with prostate cancer, you mean?
Yeah, they're now diagnosed and now they're trying to manage their disease. And,
Yeah.
you know, and we suggest at some point, you know, perhaps you just jump off one doctor and find somebody who's more cognizant of the science and treatment opportunities for a woman presenting with your situation. But in order to determine that, the woman has to know what to ask.
Yeah. So I think the big difference comes if there has been any reaffirming surgery or not. The reaffirming surgery poses both surgical challenges and also challenges for radiation therapy challenges for transgender women who are diagnosed with prostate cancer. If there has been no reaffirming surgery, I think the options are essentially the same between transgender women and cisgender men. If there has been reaffirming surgery performed, because of the creation of the neovagina, because of the modifications or alterations of the pelvic organs, I think surgery poses a challenge because with removal of the prostate, there could be potential injury to the neovagina, which is basically it's between the rectum and the prostate because of prior surgery and because of changes in tissue planes. And radiation itself can also pose challenges because the radiation could potentially have some added side effects to the neovagina. And I don't think there's a lot of experience in either of those modalities. And so it's hard to say whether one is better than the other at this point, just because I think our community just does not have enough experience with either of those.
Yeah, and it sort of raises just almost a theological question. You know, is the lack of experience because of lack of interest or because of lack of lack of patience?
I think lack of patience. I think the experience has been sort of very diluted across all medical centers. So you know, there's no sort of single center of excellence who has a lot of experience in taking care of transgender women with various forms of various stages of prostate cancer. So it's definitely not for lack of interest. I think it's for lack of numbers is one, and also prostate cancer screening perhaps may not be at the forefront of many transgender women themselves and not their healthcare providers. So they're not necessarily seen by specialists who need to offer them those services.
Right. Are you aware of any telemedicine or video opportunities for patients who are distant from anyone who's had experience?
I'm not aware of any such opportunities, but if there were some for potentially for, focus groups who could provide access and knowledge, I think that would be very helpful, definitely to the transgender women.
Yeah, let me suggest that for Beth Israel Deaconess to start a little, perhaps give somebody 3 hours a week of work and just developing a little database for that. One of the challenges that transgender women face in general is just finding a doctor who knows anything. The phrase that is commonly said, cisgender men try to find the best possible doctor, and transgender women try to find any doctor. So it'd be super to have just a central location, and Malecare could participate with that. Help.
So we do have a gender reaffirming surgery program at our medical center. That's has a multidisciplinary group between urology, endocrinology, OBGYN, plastic surgery, and the focus in that group is providing general care to the transgender women, and as a connection with us, if there are needs for those patients for urologic oncologic care, we're available and we collaborate with our colleagues. But we do have a transgender reaffirming surgery program and also transgender care program. So we do have such a center at our site, but not necessarily focused towards prostate cancer for transgender women.
Yeah, but these are good starting points.
Right.
People come to Malecare. We've been fortunate, however you want to consider being fortunate to see a lot of patients, but that transgender women are either referred to us or just organically find us. But we're social workers and psychologists. We're not treating physicians, and many of these women we know just sort of from our gut are presenting with a stage of disease that needs care instantly. It's not like many of these folks are coming in with active surveillance style presentations, and it's a struggle to help find doctors to sort of onboard them and treat them well. And then there's always like, we have to explain who these patients are, or the patient has to explain who she is.
Yeah.
Go ahead.
Yeah, so we're more than happy as the patient, as our services are needed and required to provide those services. We do have a multidisciplinary urologic oncology program between urologists, medical oncologists, and radiation oncologists, radiologists, pathologists. So when unique cases sort of present themselves that need multidisciplinary attention, we bring it to the group and we discuss it that way to provide the best possible care.
So I know you're interested in science and in marrying the idea of physicians and science to have physician scientists or scientist physicians. And that's brilliant. In social work, we try to do something comparable, but really we don't approach the level that an MD and, somebody with a PhD in biological sciences, et cetera, can sort of approach. What do you see as research opportunities around transgender patients?
Well, I think it presents an opportunity to study the disease at presentation that has never been studied before. And that means that for a transgender woman who's been on long-term hormonal therapy for feminizing hormones and diagnosed with prostate cancer, that prostate cancer by definition is a more advanced prostate cancer than what is diagnosed in cisgender women. Cisgender men. And so it presents an opportunity to study the biology of the disease in a completely different way, biomarkers that could be used and assessed for comparative assessments of presentation of prostate cancer in transgender women compared to presentation of prostate cancer in cisgender men. That in itself, I think, would provide a significant opportunity to understand the biology of the disease. And I think it's possible that the hormonal manipulation in transgender women, if you have enough data points, it could actually be a protective thing for the population as a whole. That we're sort of suppressing the growth of prostate cells and prostate cancer cells during the lifetime of an individual. That less and less of transgender women get diagnosed with prostate cancer to begin with. So I think all of those questions remain to be asked and answered.
Yeah. So as we close this out, and totally grateful for your time, we all are, including the thousands of people watching virtually behind my back here. Just want to cover just very quickly some things that you said during our conversation. About 20 minutes ago, you mentioned that MRIs, we don't know quite how we can use those as a predictive diagnostic. Were you referring just to transgender women or globally for every man?
So I was, so there's a potentially there may be used to use prostate MRI as a screening tool. And whether that makes financial sense globally or not, I think that question is to be answered. We've learned how to use multiparametric MRI in cisgender men and identify with some level of confidence clinically significant cancers in cisgender men who have not had any hormonal manipulation. Whether the parameters of that multiparametric MRI in transgender women who have been treated with feminizing hormones, whether that changes the characteristics of the multiparametric MRI, I think remains an unknown question and remains to be answered. So that in itself is an important question that needs to be answered and evaluated to see how to use this important radiologic tool, the multiparametric MRI in transgender women, and whether the parameters where a radiologist evaluates a concerning lesion, are those parameters different than cisgender men?
We've heard what I'm about to ask an insanely multiple number of times. And when I give an answer, it's an answer from a social worker. I want to hear an answer from a MD for our audience. Should a preoperative, does it make sense or is it advisable for a preoperative transgender woman who's looking at transformative, gender affirming surgery to request that her prostate be removed?
I think that also, well, I don't think there's enough experience in that. I think removal of the prostate gland, that in itself, poses a lot of postoperative recovery and challenges that I'm not sure it's reasonable for anyone to go through unnecessarily. Those being, urinary leakage that lasts for several months, potential changes in erectile function and so forth, and how the removal of prostate translates into downstream challenges for performing the reaffirming surgery in transgender women. I think that in itself will also pose challenges because of the proximity of the tissues, changes in tissue planes, and the potential success or failure of being able to perform a transgender reaffirming surgery.
Okay, great. And finally, one other sort of myth, quasi question kind of thing that, I as a social worker have no background and training to answer, nor do my psychologist colleagues here at Malecare. Does gender affirming surgery cause prostate cancer?
Surgery itself, no. And
and the hormone manipulation.
The hormone manipulation, like I said, it's possible that it may actually have a protective effect for, if you take thousands and thousands of transgender women, and only the patients who present are those sort of subset of individuals who are presenting with the more aggressive cancer. So whether it's protective or whether it is harmful, I don't think we know the answer to that. So,
okay.
But suppression of testosterone and hormonal levels is a classic way of treating prostate cancer. So it's possible that we're actually, as a whole, it may actually be more protective than harmful.
Right, but not to play journalist on this. It's possible, but there's no data to support.
Yeah, we don't. I think we don't know. So we don't know.
Yeah, it's unfortunate. I've heard a couple of doctors. I've heard investigators that I know say with absolute certainty that there, and it's just wrong to say that. We want our audience to know
that they say what that is.
That hormone therapy. I don't know how to characterize it correctly, but estradiol and hormone therapy for transgender women, for gender affirming therapies, prevents prostate cancer and/or protects against it, or makes it less likely than significantly less likely than for a cisgender male. We just don't know that. Is that fair to say?
That is fair to say. Yeah.
Yeah. Okay. Thank you. I mean, the ladies in the audience appreciate your time. The men in the audience appreciate your time. I do. And I want to thank you for the care that you give your patients, and for the training that you give your residents and fellow doctors. You are a leader in the field, and you are like an inspiration for many young investigators and many young physicians. And I'm grateful for you being, you're now part of Mailcare's faculty. So thank you for that.
Well, thank you so much. Thanks for the opportunity. I think one of my goals is to educate our physicians and our advanced practice providers that this is an emerging area, and we need to become better educated so that we can provide the best care for all of our patients. And we're happy to and we're available for anyone who thinks that they could use our services.
Okay, thank you and welcome to our conference.
Thank you very much. Thanks for having me.